KINSA president, and Katrina is KINSA vice president. She's here as well. And just so you all know, we will be recording the presentation today. So if you don't want to be in it, just turn your cameras off. And I also want to acknowledge that all of us at KINSA work, learn, and play on the land of the Coast Salish people, and at UFV, we're on the land of the Stolo people. But now, if Kristin, you want to get started, we can go ahead. Are you able, did you need to screen share, or I can?
Yeah, let's see if that works.
For you? Are you good there? Okay, perfect.
Let's see, how is that looking?
Looks good.
All right. Well, thanks for the opportunity to speak to you. And again, apologies that I had to change last week at the last second. So that was only person left who could supervise exercise in Vancouver. So it was me. So today I'm going to talk to you about the international guidelines for cancer survivors. They were published at the end of 2019. So what I'm hoping to highlight today is what was new about those and what do you need to know as exercise professionals going out into the world. So learning objectives are basically to briefly describe the development process for those guidelines. It took a lot of work, but I'll highlight the big steps of it. I won't go through all the nitty gritty. And then highlight what's new about the guidelines. And then finally, just discuss like how can we inform our exercise professionals using these guidelines. So first, development. So these are the 2010 guidelines. That was what we were updating. The 2010 guidelines were the first international exercise guidelines for cancer survivors. This is the first time there was guidelines for that chronic condition population. They were published by the American College of Sports Medicine, and it was from an expert consensus process then as well. And fundamentally, the guidelines were to avoid inactivity, return to daily activities as soon as possible after surgery, continue normal activities and exercise as much as possible during and after non-surgical treatments. And then the ultimate guidelines were the same as for all Americans and Canada as well, conveniently. At least 150 minutes per week of moderate intensity, 2 days a week of strength training, daily stretching / balance. So nothing new there. These were great because they were a guideline, so we now had one. The avoid inactivity was very well received because it was just like, can we get people moving? And then the most controversial part was this recommendation for the same as age-appropriate guidelines for Americans. Some people thought that was really too much and was going to dissuade people from wanting to be active when they were feeling not great. And wasn't there more information that could inform that? Having been part of those discussions in that room, I can tell you there was not enough evidence to really tell us it should be more or less. So we just went for health promotion. This is kind of what you can try to aim for. We had nothing that was more specific. So fast forward to 2018, and there was an effort to bring together another group to update these guidelines. So this time it was international, more so than before. It was also multidisciplinary. So previously it had been mostly exercise professionals in the room. Now we had individuals, physical therapists like myself, exercise professionals, nursing colleagues, psychology, the medical oncologists who were involved in the first one as well. Physiatrists, like everybody you can think of. And so what this is showing is just some of the American partners here on the one side, and then some of the international partners here. So I was the representative for CSEP, Canadian Society for Exercise Physiology. We also have the UK group, Macmillan, they're from the UK. We have the Dutch physical therapist, the German, I think it looks like a tornado, DVGS is the German exercise group. We had ESSA from Australia, and then a few other US groups as well. So this is a group of people that met. The hotel itself had a British beef eater theme. So that's why the door person was in our photo. We saw that person a lot and we thought that they would look great in a photo. So that's why that person is there. So the challenge we ran into for the update was that there was a lot more evidence. So this is just the classic graph when in PubMed, when you insert exercise and cancer, randomized controlled trials, you can see that there is, a kind of 200 or 144% increase in the amount of information that we're going to try and pull out from the time that we did the first look in like 2009 for 2010 guideline. A lot of information to pull from. There was also an effort to include prevention as well, which hadn't been talked about previously, and cancer survival outcomes, which was not part of the first guideline. That turned into paper one. I'm going to leave that to the end. If people are interested, I'll cover that. And then there was a lot more research on other cancer sites. Previous guidelines were mostly breast and prostate cancer. Other treatment side effects, so previously it was quality of life and fatigue, but not much else. And clinical outcomes. So does exercise help you get the amount of chemotherapy that the oncologists want to give you, potentially, which is then linked to survival? Some of those type of outcomes were now available. So what did we do? This was co-led by myself and Carrie Winter-Stone, who's an exercise professional and faculty member at Oregon Health Sciences University in Portland, Oregon. And we had a great team of members from around the world who are PTs, OTs, physiatrists, epidemiologists, whole 9 yards were on there. So we made a couple of decisions when we wanted to try and wrestle this information into an updated guideline. We made a list of all the symptoms and side effects that happen with cancer that we thought could be improved by exercise. So we made a gigantic list, and then we kind of picked like the top 15 that we thought were kind of the most relevant and had the most information. We then also wanted to use the FIT principle. A real goal of these guidelines is, can we provide a bit more specificity for our exercise colleagues who want to start using exercise as part of care? We need to have a prescription model that has a bit more of a dose relationship to it. Like, can we give people more information to work from? So this audience, frequency, intensity, type, and time, it's our bread and butter as exercise professionals and used a lot for prescriptions. So we wanted to try and give as precise guidelines as we could. Then we went and did we did a search for all the systematic reviews and meta-analyses at each of our top 15 topics. And then we were assigned in groups of 2 to delve into that literature. So what we basically determined is that if there are randomized controlled trials available, if there are less than 5 studies for a particular outcome. So let's use cognitive function, for example. So sometimes people report changes in cognition related to having chemotherapy or having a cancer diagnosis. So there's some interest in looking, does exercise actually improve cognition for those that are having chemotherapy? So if there were less than 5 trials, we would say there's insufficient evidence. We wouldn't develop a FIT prescription for that particular outcome. If there were more than 5 studies and there had to be at least 150 people in those trials, if the effect was close to 0, we said the effect was unlikely, there would be no FIT prescription. If the effect was not close to 0 and there was no heterogeneity in the direction, and I'm literally moving my mouse along here and you probably can't see that, so sorry, we're down across the bottom now. We said there is strong evidence, and the little green box was we're going to make a FIT prescription. If the effect was not close to 0, but it was a little bit all over the place, like some trials showed yes, some showed no, we basically kind of put 2 different categories. One, the effect was unlikely and there was no FIT prescription. It was just all over the map. Or there was emerging evidence of potential benefit in the higher quality or newer trials, so kind of emerging signals. And then we said there was moderate level evidence and we said we would develop a FIT prescription. So the reason I have a picture of Anna May there, she's a physical therapist and epidemiologist from the Netherlands, and she helped us develop this framework of how we were going to tackle this enormous amount of information. And it was used in the Dutch physical therapy, physical activity guidelines, from 2017. So what did we find and what's new? Why do we care about this? So the specific exercise prescription. So what's not new is that we did endorse what was previously found. So we have sort of a model here where at first, avoid inactivity. Same as the 2010 guidelines, that's our primary recommendation. And we just said moving more and sitting less benefits nearly everyone. We couldn't say everyone because of course, as you have clinicians in a room, there's a lot of what about this, what about that? So we went with nearly everyone. Then for overall health, we suggested that you aim to meet the current physical activity guidelines for adults because that is the guideline for overall health and well-being. So the similar 150 minutes per week, moderate to vigorous, consistent with what we know about those guidelines. What's new is then what we said after that. So there's a lot of controversy about this infographic. We can talk more about that later. But what we were trying to show is that we saw a signal for some common side effects of cancer diagnosis and treatment where a lower level of exercise might be beneficial. So what we've shown here is we did develop a fit prescription with strong evidence for cancer-related fatigue, health-related quality of life, physical function, anxiety, depression, and there was moderate evidence for sleep. We had a fit prescription for lymphedema and moderate evidence for bone health. What we tried to do then is say that you can also, whether it was aerobic exercise only would be beneficial, whether resistance exercise only would be beneficial, or the combination. The idea here is that if you are experiencing cancer-related fatigue, for example, to improve these symptoms, you can choose one of these exercise options. And so color coding wise, what you can see here is that for pretty much everything except for lymphedema and bone health, the light blue and pink, 30 minutes, 60 minutes of aerobic exercise 3 times a week should show benefit for those outcomes. If you want to do resistance training only, for example, that's what you like, that's what you would like to do, you should see a benefit for fatigue, health-related quality of life, and physical function. But for anxiety, depression, sleep, we didn't see a signal for resistance training alone. For lymphedema, we saw that it's a bit of a different recommendation. There's no increased risk of developing lymphedema, which I'm happy to talk about with resistance training. And that bone health definitely showed a benefit with resistance training only, but not aerobic only. And then we did see with the combination, there was a signal for that if it had been tested. And what we see here is that you can do slightly less aerobic activity if you add in some resistance training and still see some benefit for the majority of these outcomes. So now it's only like 20 minutes is your bar for aerobic. And you can, if you do strength training as well, then you don't have to use 30 minutes of aerobic. So that's what we're hoping to convey, is this kind of complex prescription piece. And the idea being, if you're feeling a lot of cancer-related fatigue, like where would you start as a person to start, addressing this with activity, or as a practitioner? Like you meet someone, they're talking about cancer-related fatigue, they talk about having running shoes, but they don't have weights at home and they really want to just do aerobic activity. Great, there you go. If someone loves resistance training, they did it before, they don't like walking, they don't have a bike, whatever, maybe you can be like, great, we'll get you going on that with some TheraBands or some weights, and this is the kind of effects you should hope to see. Well, we tried, this is it was supposed to be our patient-facing infographic. Apparently it's too complex and no one liked it, but we can talk more about that if anyone wants to. What we also made was kind of a clinician-facing one. And so what this was is a kind of a cheat sheet for you. If you're working with this group, you probably just print this off, laminate it, keep it in your clinic. Here's kind of the main dose for all those different conditions. So if someone has anxiety and depression, this 30-minute bar 3 days per week, they should start seeing some benefit if you start prescribing that, and they can work up to that. So that's the aerobic only. We have the resistance only as well. And what we basically did is, you can see there's a little bit of difference between these, and it was all based on the research. We just pulled the studies, and this is kind of the amount that people saw that was beneficial. Ideally, members of the group wanted to know what the minimum prescription would be, like here's the minimum bar, but the evidence we have just isn't sufficient. There's not enough head-to-head comparisons of 30 minutes versus 60 minutes or aerobic versus resistance to get that specific. So we just kind of pulled any study that showed benefit, that was good quality. We looked at what that was and tried to sort of summarize what's the kind of, first kind of signal was. You'll see here for anxiety and depression, we didn't see anything with resistance training alone. And what's covered, unfortunately, by my adding this link in, is that with lymphedema, 2 to 3 times per week of progressive, supervised, exercise with major muscle groups did not exacerbate lymphedema. So for lymphedema, it's a swelling of the arm that can sometimes happen after breast cancer surgery because the lymph nodes in the armpit can be disrupted by the surgery itself, or sometimes people get radiation to that axilla because they're worried that any cells that have left the breast that might be metastatic go into the lymphatic drainage, and so they try to maybe hit the first couple lymph nodes with radiation to prevent more metastases. So there was a lot of concern that using your arm would increase your risk of lymphedema. And so that's a whole nother talk, which I'm happy to give as well, about all the myths around that have been disproved. So now there's enough evidence to say that if you do slow, progressive resistance training that's sensible and doesn't have huge changes in progression, that it's safe for people who are at risk for lymphedema or who have lymphedema. And my last animation is just that combination. You can see here now, you can sort of get away with 20 minutes of aerobic activity if you add the resistance training. So this was our our practitioner-facing infographic. It's available on the ACSM website. And someone just alerted me it was one of the top 5 downloaded infographics from ACSM in 2020. So there's something good that came out of 2020, I guess. I can put that on my CV. So that's great. So for the modern evidence, just to kind of round this out, we did see there's some emerging evidence for the bone health and sleep outcomes. So what we saw for sleep, aerobic activity alone, a little bit higher threshold potentially. You need to do 3 to 4 days per week. A moderate intensity might be beneficial. And bone health. Obviously, this is not a news probably for anyone in this group, because changing bone, you have to give it quite a stimulus to really impact it. The reason bone health is important for cancer is that common treatments for breast cancer specifically and prostate cancer most commonly, they use anti-androgens or anti-hormonal treatments. And so that can have a negative effect on your bone health. And so there's a lot of interest in trying to maintain bone health when people are on these long-term hormonal therapies. What we saw is that 2 to 3 days per week of moderate to vigorous resistance training plus high impact training sufficient to generate ground reaction forces of 3 to 4 times body weight for at least 12 months. So, you know, if you want to change bone health, you really got to dig into it and give a real bone focused prescription. But there is emerging evidence that you actually can try to maintain or prevent the loss of bone with some of these hormonal treatments. Building bone, not quite sure we can do that just yet, but that's what we found there. So those are the guidelines. I'll briefly go through some of the exercise clearance and triage as well, because this changed from 2010 as well. And a lot of it was driven by the fact that ACSM changed their way of doing pre-participation screening as well since 2010. So this is the 2015 version of the pre-participation. And you know, for those that have looked through this, it really is just really focusing on cardiovascular disease, metabolic health or renal disease, and the signs and symptoms. So we use this as our jumping off point as well for using our triage for cancer patients. What you will note is that there's nothing about cancer in this. So this is kind of our benchmark framework and nothing about the adverse effects of cancer treatment. So what we said then is start by looking at your underlying cardiovascular disease risk factors and triaging based on their presentation generally. And then we moved on to giving guidance around the cancer specific elements. So this is what the table we developed looked like. We used a framework that had already been developed by this group called the NCCN, which is the National Comprehensive Cancer Network. They had developed this kind of model of who's at sort of moderate to different risks previously. So we thought it did fit well with what we were seeing. So why create something else new that was pretty similar? So you can see here, if people had no comorbidities and they passed a previous screening, then maybe no further pre-exercise medical evaluation was needed. And you could just follow the general exercise recommendations. These people are no different. You just, you know, you are aware of the signs and symptoms of the cancer treatment, but proceed onwards and just monitor someone's response. Then there were some conditions, which is the second line, that you might want to consider a referral to a trained professional. If you follow that little asterisk down, that was a rehabilitation specialist, physical therapist, OT, or physiatrist, or a certified exercise physiologist. We gave examples from US, Canada, and Australia of ACSM CEP, a CSEP CEP, or a ESSA AEP. That is obviously not exhaustive, and if it's used in another country, they can insert whatever they think is right there. So that's things like peripheral neuropathy, a common side effect of some of the chemotherapy drugs, arthritis and musculoskeletal issues, a real common side effect of the hormonal therapy given to women with breast cancer that they have to take for about 5 years, poor bone health, which I mentioned previously, osteopenia or osteoporosis, and lymphedema. So if people had any of those conditions, then you would recommend a pre-exercise medical evaluation, which as per the NCCN guidelines was basically whatever the physician wanted to do, not necessarily specifying a graded exercise test or anything that's prescriptive. And may want to modify the general exercise recommendations based on your assessment. And consider referral to a trained professional. Then the last group was kind of the very complex people, and that's where it was referral to a trained professional. I would say is recommended. We didn't put that in there, but I think that was it was like, please refer these people. And that's people with lung or abdominal surgery until that's sort of healed, ostomies, cardiopulmonary disease, ataxia, extreme fatigue, severe nutritional deficiencies, worsening or changing physical condition like lymphedema exacerbation, or individuals that have bone metastases. So the cancer is spread from where it started out to a bone, which is pretty common for some cancers when it does spread. It likes the thoracic and lumbar spine. It likes the clavicles. It likes the trochanter of your hips, your parts of your pelvis. Different cancers kind of go different directions, but that's when it becomes a little bit more challenging to prescribe exercise. So you can see if you're thinking about, who we have in the room here, I think everyone's kind of gearing up to sort of end up with training for the CEP. So you could see any of these people. And I think the more training you'd have to work with this group, you might feel more comfort with, depending on sort of what presentation people have. And this last group is the more complex. It's just the reality. And we hope that there's physical therapy services at VC Cancer that can grow, that can address this group, and then maybe triage people or graduate them out to the community to see CEPs. But that's kind of our dream. And then we had some other considerations as well. So we did want to mention giving guidance in the text form around bone metastases, like what specifically might you want to do there, and some of these other considerations. The reason the last two are in blue, symptom clusters and sun safety, those were added. That was new to the 2019 guidelines. We had information on the other kind of special considerations in the previous guidelines. Symptom clusters really are the recognition that if someone is presenting with fatigue and anxiety and depression, these things kind of can coexist. And so, what prescription would you pick? You can start with whatever you think is the most relevant for that person and go from there, and just recognize it kind of comes together. And sun safety, one of the sponsors was the National Cancer Institute in the US, and they have a big sun safety campaign, so they would not let us out without saying things about sun safety. If you're active outside, you should take sun mitigation strategies, sunscreens, hats, long sleeves. And there is an increased risk of potentially side effects of some treatments if people are in the sun while they're on treatment. So just being recognized. So that is kind of the main pieces of the 2019 guidelines. They are not without limitations, so I will definitely acknowledge that. The majority of the research that we use to inform these guidelines is still in individuals with early stage breast cancer and prostate cancer. Those are the two most common cancers for people in Canada or Western countries, for men and women respectively. That's where most of the research has been done. There is more research in other cancer types that's emerging, but even while that happens, more research is done in breast and prostate cancer. So I don't think we're ever going to escape from that. It just keeps perpetuating, but we have more information now to really inform the guidelines. There's really little information in advanced cancer. This guideline really doesn't handle advanced cancer. So that's anyone that has a metastatic disease, so bone metastases or even metastases to other organs or parts of the body. There's not much research on that. We really couldn't cover that in the guideline. As I mentioned, we really, as exercise professionals, wanted so much fit prescription in there. It was just gonna be amazing. And what we really saw is that there was limited head-to-head comparison trials of different types of exercise, different doses of exercise. And so we really can't say, as I said, what the minimum is. We know what should be beneficial, but we don't know upper or lower. It's just we don't have enough trials at this point to inform that. And there is limited research on other modes of exercise. Yoga, Tai Chi have all been investigated in the cancer population. Those were a little bit harder to put into a fit principle, for one. And then there's just limited evidence. There wasn't sufficient for us to be able to make recommendations. If you are interested in other types of exercise, there are good meta-analyses and systematic reviews on yoga and cancer. So I would encourage you to check those out if that's an interest of yours. So that's the guidelines. Are there any questions at this point? I don't know what will happen. I can't see the chat anymore. Are there any questions in the chat or any questions anyone wants to ask at this point before I go to our effort to translate this to our clinical colleagues in oncology? Oh, a great infographic. Well, thank you.
Kristin, if you're taking questions right now, I would ask if you go back to like that PubMed graph that you showed, where once the first guidelines were published, then the amount of research seemed to increase even more. So I was sort of my first question was, do you think that then drove some of the research? And then my second question is, if you were to do, or if one was to do the same kind of thing with high intensity interval training, you might see a similar trend, probably somewhere around 2010 or a little bit before that, HIIT research really explodes, and it certainly infiltrated other clinical populations, maybe more, but I'm just wondering if you could like speak to that. You kind of spoke to that in your last slide, but I'm just wondering if you'd speak a little bit more to that as a dose, I guess, or whatever. Yeah, thank you.
No, I think it's a great question. And so I definitely feel like that 2010 guideline brought greater awareness to exercise and cancer, and kind of maybe brought more people into the field who wanted to research. The flip side of that, I've heard the cynical person is like, you could put anything into PubMed and there's just so much more research being done and published that you can get the same graph no matter what it is, right? And so I can't say for sure, but I do know that the guidelines kind of allowed us to arrive on the map, I guess. And at ACSM, there now is there always was a cancer interest group, but now cancer is kind of one of the pillars of when they do the program. Like cancer has its own thing. Cardiovascular disease has, I don't know what all the things are at ACSM, but cancer has its own home now. And so I think that will drive potentially more researchers to come into the field and bring more ideas in for sure. Yeah. Okay, so then what we also did, there were 3 papers that came out of this. I just showed you the guidelines, which was paper 2 technically. All the prevention stuff was paper 1. We might get to that. And the 3rd paper was our effort to try to take the guidelines and package it in a way that we could get our clinical audience. So that's the medical oncologist, the surgical oncologist, the nurse practitioners, surgeons, anybody working in this area to kind of take notice of it. So this was what we said: exercise is medicine in oncology, engaging clinicians to help patients move through cancer. This paper was led by Dr. Katie Schmitz, and she was sort of the main instigator of this update guideline. So she was sort of a leader through this. This was published in a journal called Cancer Journal for Clinicians. And so it was one of the most read by that audience. So that's why we really wanted to get it in there. The previous paper was an MSSE connected to ACSM. So what did we do here? So the background was really, well, why do we even need to talk to clinicians? Don't they already know exercise is good? Like, are they prescribing it for their patients? And the answer is no. Why don't clinicians talk to their patients about exercise? One, lack of awareness about the potential value of exercise for this cancer population. The 2010 guidelines were only 2010. It was only 11 years ago, and so it is relatively new in the grand scheme of exercise rehabilitation for other conditions. Cancer is definitely a new arrival. A lot of uncertainty regarding safety or suitability of exercise for their particular patient, without understanding that there's a program like, say, cardiac rehab or pulmonary rehab, where it's a known entity, you check a box on a form, you send someone down the hall. That doesn't currently exist or hadn't existed for cancer. And so it really was like, what are you telling my people to do? And they're complex, they've got a lot going on. Like, I just don't, if there's not a program within the cancer center, I don't know what you're asking them to do, I'm not gonna refer. Lack of awareness regarding available programs, so to help facilitate exercise. So some of the challenges that there aren't a lot, and so there's even if they are, there's not a lot of awareness about them. And then the belief that referrals to exercise programs is not really within the scope of practice for oncology clinicians. They are experts in chemotherapy and treatments around that. Exercise is like, I don't know, it's probably important, but it's really outside of what their training is and what their comfort zone is. And traditionally within cancer care, there were referral pathways for things like registered dietitians. If people were really struggling with nutritional intake, that was available at the cancer center. There was supportive care around psychosocial and patient and family counseling that existed. And physical therapy, rehabilitation, exercise was just universally not part of the conversation. I think a lot of that had to do with the fact that cancer prognoses have improved drastically in the last 50 years. And the idea before, and the cancer treatments have also improved. So previously, the idea was that you had cancer, it's a pretty significant diagnosis, the treatments are terrible, but we saved your life. So the fact that you have a lot of side effects from the treatment is an unfortunate issue, but you're still here. And so I think with the improvements in cancer treatment and a lot more advocacy from individuals who had had a cancer previously diagnosed, what pushed this field forward as well. Because people are like, why do I have this peripheral neuropathy? How do I improve? Like, can I be active? Without those questions, the survivors really pushed it forward more so than I think the clinicians in this field. So what the recommendation from this paper was, it was kind of distilling down, like, what can we get the oncology clinicians to actually do? We tried to apply this sort of exercise as medicine approach that's been used at ACSM, assess, advise, refer. So could we just ask people to say, currently, are you exercising 3 days a week for 30 minutes? Yes or no? If no, there are some resources, hopefully within their cancer center. Please go and see this and refer to anything that actually exists. So that was the idea. It's not that out of the realm of possibility for oncology because they do this with distress screening. So when people come into the cancer center, say at BC Cancer, they are given a distress thermometer and they have to mark where they are, and there is levels. If you are this, you get sent this. If you're this, you get referred that. So it's not totally foreign to this group. We just want them to do it with exercise. The biggest challenge then is refer where, to what. And so what this group has tried to do as well is have a comprehensive directory of services in the community. So someone who's a practitioner or someone who has cancer themselves could go and look at this, enter where they live, and resources and programs will show up. There is a vetting process to be part of this, and it's going to be looked at every year to make sure it's still current and to try and make sure they are high quality services. It's a challenge. It's been available for a year, so there's a lot of growing pains here, but that's the effort on the referral piece. And I think just for this particular audience, there was a lot in this paper trying to educate the clinician about what kind of variety of services there are and who delivers them and what might be more appropriate for one group than another. And so this isn't my favorite graphic, but what they were trying to show is that there are community exercise programs, which are supervised potentially or self-directed. And so if you were in a community-based program like OsteoFit, let's use that as the example, it may be a nurse or an exercise physiologist delivering that, and it's at a community center potentially, or a fitness center or home. And that is very appropriate for some groups. Or they may just be in a community center. There could be a cancer and exercise class for those that have finished their treatment, and a fitness professional is leading it. We do some work with BCRPA and community centers in British Columbia for a project with men with prostate cancer, and it is fitness professionals that are leading that program, and it's just at the community centers. You sign up like anything else. The other end of the spectrum, so if you move all the way over to, I guess, the right for you, the red, trying to make practitioners also understand that there are programs for those that are more complex or need higher level supervision or more intensive work. And the example here is someone with, fatigue or someone really struggling. There can be more medically based exercise programs. So more like a cardiac rehab or a pulmonary rehab that's actually based in the hospital, or inpatient and outpatient PT, rehab services that could see these individuals. And these are the kind of people you might be looking at to deliver that. You could see a physiatrist or a physical therapist or a clinical exercise physiologist, OT or nurse, where the fitness professional is probably not seeing that group because that's just not within their scope of practice. So just a little bit of education potentially about programming, who exercise professionals are, knowing, it's incredibly complex. I'm sure everyone here has sort of had to try and define who they are, what they do, where they can do it. So just trying to give some information about that. So this paper also, acknowledged there are many barriers to overcome with this approach to trying to assess, advise, refer. Programs really vary by geography. Canada's a perfect example. BC, we've got some programs in the Lower Mainland, get thinner as we go out from there. We tried to start the Men with Prostate Cancer in person in Prince George. People were traveling too far to come for a supervised exercise program in person 2 times per week. They were just like, no, I can't drive an hour and a half, 2 hours, 3 hours to come for an hour of exercise. Supervised programs tend to net better outcomes. This is what we saw in the guidelines that I didn't highlight that, but supervised programs had more of a signal, and that's not a shock to anyone on this call. We can individualize the exercise better. We can provide motivation. We're there tinkering around. People have accountability. It's not unheard of. So funnily, this was published in 2019 in November. Could technology help? I wonder, do you think we could use that? And I think we've learned the lesson that some of the main barriers around that, there's a lot of concerns about privacy, older adults not being able to use technology, like all of those things we've just leaped over in one big hurdle with COVID. And so I think there's a lot of potential here, and I'm happy to talk about how we've done that. And then recognizing there's a lot of behavior change needed. So, patients, or more so their families, a lot of times people are trying to do everything they can to support someone going through cancer. They want to make their life easier. They want to do everything they can for them. And so getting up and walking and being active, sometimes family members are like, oh, it's too much, don't do it. And so, just getting the recognition that, some level of activity is good, getting out walking is good, support your family member, just helping people understand what's safe for the patient themselves as well as their family members. Physicians, members of the healthcare team, getting them to, understand where exercise fits, do the assess, advise, refer, and in the community, like getting people out and being comfortable, with exercise trainers, seeing people with cancer and feeling like they have the skills and knowledge to really work with that group as well. This is one of those terrible busy slides, and I won't belabor it here, but it is really a call to action that we tried to put in this paper, that you can find yourself on there, like, how do we move this forward? And I'll just highlight maybe the mainstream health and fitness industry. So provide high quality programming to large numbers of cancer patients worldwide. Somewhere like Good Life in Ontario, they want to host these programs. Like, how is that the right place for these things? Can we upskill a workforce that can work and use that framework? Things like that. I guess we're clinical educators, so expand physical activity education in terms of training all healthcare providers who are or willing to be part of the oncology workforce. So that's our job, Jason, Jillian, and I, like, how do we give the people who are coming through our programs these skills so that they can work in this field? So just, to summarize those 2 papers, how they're in evolution. The first paper, the guidelines paper, does provide clinicians with greater evidence for specific exercise prescription to address key and common side effects and symptoms of cancer treatment. And the translational paper, the one I just talked about, it's a call to action for oncology team to get engaged, assess, advise, refer, and it really called to us on the other end to have places for people to be referred to. So what do exercise professionals need to know? I'll just kind of close with a few ideas around this and maybe just highlight what is available in BC, like what resources and education are available. So one of the things that's challenging as an exercise professional when someone comes to see you, you've done your screening, you've done your triage, you've gotten your prescription out to see what you're going to do, especially those that are on treatment, there's a lot of ups and downs people typically get chemotherapy in a cycle. And the cycles are usually 2 or 3 weeks long. And what that looks like is someone gets a drug, probably by IV, on day 1. And then they wait 3 more weeks and then they go back for their next dose of that. The reason it's given that way is typically because it is pretty hard on the body. It's trying to track down all the fast dividing cells in the body to eliminate any potential of metastases. And so it's, all the things you think about, fast growing cells, hair follicles, lining of your GI, so some of those side effects you're used to seeing, hair loss, nausea, diarrhea, things like that come with chemotherapy. But also cancer cells are fast dividing, and so that's how they hit that as well. But the result is with these cycles is that people have a lot of fluctuations across the 3 weeks in how they're feeling, what their blood work looks like, all those sort of things. And typically, the idea is that by 3 weeks, your body's recovered enough to get the next dose, and you just repeat that for like 6 cycles. So this is a nice paper from Daniel Santamina from University of Toronto / University Health Network. And I worked with him on that, and it really was to give exercise professionals a little bit more sense of like, well, what blood values do I care about? What heart rates and blood pressures are things I need to worry about? I won't go into bone metastases too much today. And variations in physical and cognitive presentation. People feel more fatigue a few days after chemotherapy, start feeling a little bit better. So we've tried to titrate exercise based around that. And people talk about chemo fog, like they just can't concentrate, they're just not feeling as sharp. And so, how do we make exercise easy for them? So we have a nice little checklist, microscopic font, I appreciate. So this is just a highlight that this exists in that paper. And on the next slide here, I've tried to blow up the heart rate stuff. So here, for example, resting heart rate greater than 100 is resting tachycardia. So if you crack open the ACSM guidelines for exercise testing and prescription, that's a relative contraindication to exercise in the general population. We see that all the time in our practice. And what we think that's about is that right after treatment, people get kind of volume depleted, like they're not feeling well, they're not taking as much in. And so blood pressures really start dropping a little bit. And so to maintain cardiac output, if we want to go back to our exercise physiology, you want to maintain your cardiac output, you have to keep your volume up or you got to pump your heart more. And so we see a lot of resting tachycardia. And so what this checklist was trying to do, if I got this in right, was saying, giving you some guidelines. For example, with resting heart rate, if it's greater than 110 after 2 measurements 5 minutes apart, then you need to have doctor's clearance. But up to 110, we're really willing to go with that. And then we also have difference for systolic blood pressure. Oh, sorry, that's for blood pressure. Where's my heart rate? Our resting heart rate, greater than 120 after 2 measurements. And then for our blood pressures, even if people are hyper or hypotensive, there's a lot of variation. We've kind of, with experience and having done this work, we have a bit wider range. So if you're going to work with this group, I'm just highlighting that paper for you. It would be a good resource to have. And then within BC, so you're working with this group or you have a friend or family member that wants this information like exercise and cancer, how does it work? There now is an exercise support page at BC Cancer. This is in the last 2 years, we've been able to get some space on the website and get approvals. So there is information there. It has common questions, what the recommendations are, some additional resources, patient handouts, how to find a trained exercise professional in your community. That all exists there. We just finished filming some videos. So now, as of a month ago, there's now 6 exercise videos for breast cancer. It was funded by a group that wanted to fund breast cancer. So we have 6 videos, basic introduction, immediately post-surgery, and then kind of progressing from there. So you can check those out. And then we also have a prescription pad for the oncologist. So they always want, this is the funny story. So one of the oncologists said to me once, oh, I just tell my people to be active. Like I tell them to go walk for like 60 minutes a day. And I was like, oh, and you're having some trouble getting uptake with that. I'm not surprised. I mean, that's the kind of thing, like if you're not active at all and someone tells you to walk for an hour a day, you're like, I don't think so. And so what we thought would be a good solution for that is kind of this prescription pad, then that oncologist who in the goodness of her heart wanted to get people to be active and really felt it was beneficial, can just tear this off the top and hand it to people. And it's a little bit more realistic for where to start at least. And then we'll connect people to the exercise support page. And if they want more information, they can kind of zoom out from there. But this is just the avoid inactivity. This is our symptom management guideline for kind of what was a bare minimum to try and remove symptoms. And that's what we put on there. And then some links to CSTEP and Find a Physio. We also developed a referral pathway. There is an exercise specialist at HealthLink BC. So we upskilled one of the people who was already working for the physical activity line there. And now they have more comfort and experience dealing with cancer-related calls. So this was a project we did with Michael Smith and HealthLink. And so you just call 811 and you can talk to an exercise professional who's experiencing cancer. Or we also developed the referral form, so the oncologist can actually refer their patients to the 811 line, and the 811 exercise professional who's specialist in cancer can call the patient directly. So that was really exciting to have that capability as well. So last but not least, I just wanted to highlight some ongoing research, sort of where we're trying to add to the 2020 guidelines or whatever they will be. And kind of where the field is going from our standpoint. We do have an ongoing randomized trial of exercise during or after chemotherapy to understand whether the timing of that helps with cancer-associated cognitive function 1 year after treatment. So exercise is a little bit harder to do during your treatment. You don't feel as well. We can't deliver quite the same dose, but maybe it's really important to do while you're having chemotherapy, or right after you finish. It's a little easier for us to give you a bit more of a dose of activity. You can hear a bit better. So at 1 year, does that change where you're at with your cognition? Just starting a project called BFit, Breast Cancer for Endocrine Therapy Fitness. This is in women that take 5 to 10 years of long-term aromatase inhibitors or tamoxifen or anti-hormonal drugs. They've had surgery, they may have had chemotherapy and radiation, but now you stay on these for 5 years to decrease your risk of a cancer coming back. A lot of joint pain, myalgias, arthralgias, aches, pains, and there's been some suggestion that exercise helps you to manage those or just makes you cope with them a little bit better, and might help you stay on the, adhere to the medication. There is about 50% of people stop this within 1 year of starting it because the side effects it just is a real impact on quality of life. And so, could an exercise intervention help you manage those main side effects and help you stay on the treatment? And that might improve your survival long term. We also have Survivor BC, which is our men with prostate cancer exercise program. That's in partnership with BCRPA. So we are running fitness classes for men with prostate cancer at community centers around the province. This one is a subscription-based fee. So we run it like you sign up for insert whatever you like at a community center. So that's an interesting challenge. Like, are people willing to pay for this so it can be sustainable? All the work we've done to now has been research. So you come in, you do your research trial, you pay for your parking, all those sort of things. As we try and take it into the community, are people willing to pay for this? And if so, how much? And how do we get people to see the value in it and be willing to pay if they haven't been engaged with the community center before? And then we also have some various physical therapy related projects. We have a big cross-Canada network of ourselves, University of Toronto and New Brunswick and Nova Scotia, New Brunswick and Newfoundland, looking at how we can improve identifying physical impairments in people having cancer treatment and triage them to actual rehabilitation services. There's a big gap there, so we're working on that. And then we've also done a lot of work if women could kind of do their own post-operative breast cancer rehabilitation. And here you see people measuring their arm. We want to track lymphedema carefully because the sooner you identify it, the easier it is to treat. And so in the old day, not even old days, the common way of doing this is that you go to see a physiotherapist to have your arm measured. You go periodically 4 times over the year after you finish your treatment, for example. But that has a huge patient burden, having to go, time, off work, parking, blah, blah. It's a big drain on their healthcare system to have the PT time to do this if everything's fine. So we asked the question, could women measure themselves? We thought no, because as physiotherapists, we learn a lot of landmarking. You've taken probably your anatomy classes and We use surface anatomy, and we use a special tape measure to make sure we keep the same tension on the tape every time. And what we found out is no, women are just as reliable at measuring themselves. We gave them a kit. It was like a body composition tape you'd use for your biceps, to see how you're, improving there. We gave them a stir stick from Starbucks. I thought we did purchase popsicle sticks from Michael's, but no. Apparently the grad student grabbed a handful of stir sticks from Starbucks. No wonder they've all gone out of business. And we basically sent people that, and they measured 4 points in their arm, and they were as accurate as a physiotherapist that has measured 1 million arms and was the expert in BC, and against this thing called the perometer, which actually is this infrared scanner that you scan over the arm, and it takes a volume measure of like kind of what's been disrupted. And so you can use these measurements to calculate a cone. And so it was amazingly accurate. So we've translated it to Punjabi, and we're working with Surrey Memorial Hospital to do a whole virtual self-measurement, virtual PT post-op care model. We were doing that before COVID, and now we're definitely doing it because of COVID. So that's kind of a snapshot of sort of the guidelines, what's available in BC if you want to get into this, and acknowledgement of all the people that have kind of contributed to a lot of this work along the way. So I'm happy to take any questions in the chat, or if you want to unmute. Oh, and Iris. Hello, Iris. Your name is on there too for your nice work here as well. And I hadn't seen your new arrival yet, so hello.
Yeah, well, it's very noisy in my house, so I don't know how long I can unmute for, but this is Kaya.
Fantastic. Very nice to meet you, Kaya. And Iris is working on a project with us with ovarian cancer. We're just about to start, so that's pretty exciting too, called Be Balanced.
I don't want to cut off any students, but I do have a question if nobody else has one. So you're talking a lot about the implementation in translational research, and what I always struggle with, and students who have worked with me like Katrina might know this, is how to actually get patients involved. So I'm starting a program called the Walk It Out program with a national survivorship group. And the idea is to have community-based walking pods and have an ambassador lead them. But we don't know how to find people. So that's always our biggest challenge.
Yeah, it's there. I feel like, well, it'd be interesting. I think there's a lot of the support groups where there's keen being people. They're out there. When we do look for patient partner engagement, there's people that are like, oh, I'll come in your study, I'm super active. And you're like, oh, great that you're super active. We actually don't need you because you're doing fine. We need you to help us find the people that haven't been able to integrate this in their life or didn't have a previous experience. So I think I'd be happy to work with you. The BC Cancer has a system where you have to officially go to get their patient partners, but we've been successful. You get to put it in a newsletter. And so I think that would be pretty attractive, and I'm happy to chat with you about that. I think the sustainability piece is really hard because even with the Survivor program, what we did is the first time you enroll, you get it for half price, and then you have to pay the full pop next time. And so people stay. Like once you're in the door, they love it. They see how much better they feel. They connect with the other people there, even virtually. The men talk to each other on Zoom. It's amazing. But to get people in the door is the hard piece. Like people, if you don't know how an exercise class works and you haven't seen the benefit, you don't get the feeling of improvement, then it's just like, oh, I don't know. I don't think it's for me. And so I mean, obviously it'd be ideal if it was free, but the community centers, like they already give us the room for free and everything else. We have to pay the instructor. That's all there is that we're paying for. So that piece has been challenging to me. So yeah, I don't know if I have a total solution, but I'm happy to talk to you at any time you want about that and work with you to find some options.
Okay, well, maybe I'll touch base with you about that. And if there's any students that are interested in that type of research, you can also contact me. I'm technically on maternity leave, but you know.
I've got a couple of questions. I'll just ask one, and then if no one else jumps in, I'll come back for my second. So you alluded to your survivor study being done over Zoom and the men talking to each other over Zoom. So my question was kind of along those lines. I was going to ask if you are doing research like with virtual exercise, and I guess my real question is the barriers that you identified in that 2019 paper. are they as big as you had thought? And like, what barriers have you had to overcome?
Yeah, so we did, like everyone, realize that we had to switch potentially to online with COVID. So we, one of the main things, well, one, delivery of the exercise was one challenge. Two, a lot of our in-person programming, the social support is the big part. And I'm sure Iris can attest to this as well. People get, they talk to each other, they are interacting with people that have had a similar experience. So as much as their friends and family members are supportive and want to help them, it's just, they can't have the same conversations. You have to, someone else has gone through it. So our big concern is, how do we duplicate that in the virtual setting? Because as much as we like to think they're coming to walk on the treadmill, they don't care. They just want to come at the same time as their friend so they can talk to each other while they're on the treadmill. And so we've actually been, we've done like honestly little icebreakery games. So it's a 1 hour session. The first 10 minutes, we have like a topic, like insert whatever, like non-political news story, like something, just to get people talking. And then we open up the session 15 minutes early, hoping that people like get on so that Zoom works and we can work through the troubleshooting piece, but we aren't there technically. And so eventually they just start talking to each other, and they get a lot of the same social support stuff in our pilots so far that they kind of got in person as well. So we're really happy with that. But I think opening it 15 minutes early, having something at first like icebreakery to get people kind of talking to each other, and we keep the same group over the 6, 8, or 12 weeks, depending on the intervention, to kind of maintain that group dynamic. We've also measured group belongingness on a scale that Dr. Guy Faulkner from UBC Kinesiology gave us, and people feel kind of connected. So that's been good. The other barriers to your question about, do oncologists recognize it exists? Are they willing to refer patients? I think that takes a lot of work. We've had a lot of inroads at BC Cancer Vancouver because I've been here for 11 years. Before me was Dr. Don McKenzie, who was at UBC Kinesiology, who had done this for another 15 years before that. So I think BC Cancer Vancouver are on board. We've demonstrated capabilities. Their patients have so far, touch wood, been fine in this interventions. They have the exercise videos, they have the prescription pad, like they're into it. But it's because we're here as researchers and we've done those engagements. There's no exercise professional within the BC Cancer system. And there's one physical therapist for the whole province, and she's based in Vancouver. So there's 6 BC Cancer sites all around the province. There's one PT. So I think it just hasn't, the referral piece is still a big gap. They don't know where to send people to. There's just challenges. There is a group called Inspire Health that has pockets around the province as well that does deliver exercise programming for cancer patients. In the past, the exercise professionals were more on the fitness professional leader level, so the complex people weren't really well served. They have been adding more certified exercise professionals there, so that's improving as well. And it's, I think, paid for by the Ministry of Health or something. So that's one community service but there's some reluctance. There's a little history there about referring people to that, but that's a big gap. There's no services in BC. Other provinces have gotten a better referral pattern, but still a challenge.
I actually had a question. I'll just introduce myself. My name is Haley Milburn. I'm a student of kinesiology at UFB. So you were mentioning prescriptions and patterns there. I was just wondering how much research had been done on like lifestyle physical activity. So like grocery store shopping, like gardening, that kind of thing.
No, it's a great question. And so what we did with those guidelines is we took randomized controlled trials of structured exercise. So we did not look at physical activity or all, sort of the things you're speaking about. Where that has been looked at is in the epidemiological research. So looking at, if you're more active before, does it decrease your risk of getting certain cancers? That is reflected there. If you are more active after your cancer diagnosis, do you have a decreased risk of your cancer coming back or surviving that cancer? That's where some of that comes in. So they've looked at the self-report questionnaires around what kind of activity are you doing? And that's where you'll see some of the lifestyle activity. And I can share my screen briefly, and I can sort of show that paper very quickly because I didn't want to spend too much time on that. But the paper is here and is led by Alpha Patel and Chuck Matthews. And what they basically saw is that for about 7 different kinds of cancer, 1, 2, 3, 4, 5, yep, they saw a reduction, maybe an increased risk of melanoma in those that were more active. And that has a lot to do with sun exposure related to being outside more. So if you were doing proper sun safety, this probably wouldn't be as much of an issue. But why I wanted to show this is looking even at what we can recommend for people after their cancer diagnosis. And again, this is where the physical activity, it is things like Met hours per week. So they've asked people, what are you doing? And they've looked at the compendium and lined everything up. And the more Met hours you have per week with breast, colorectal, and prostate cancer, that the more active you are, you see a decrease in cancer-specific mortality of about 30%, and all-cause mortality in a bit of a wider range here. So that's where that's kind of reflected. Of course, everyone wants to know, after they've had their cancer diagnosis, how much do I have to do to not have my cancer come back? We are nowhere close to knowing that answer. And so the exact dose of physical activity needed to reduce cancer-specific and all-cause death is not yet known. Too few studies have been conducted that have detailed data on the risk association for specific doses of activity. So it really is kind of a broad brush at this point of just Met hours per week, which we all know could be anything. Like I could walk forever and I get the same Met hours if I did 3 interval training sessions, you know? So I think some of that's reflected, but there's a lot we need to know about that. That's a great question. And I think for the most part, a lot of the interventions are walking and just getting people moving. So I think that is heartening to me. It doesn't have to be complex. Jonathan Little from UBC Okanagan gave a talk in one of my classes today about diabetes and, you know, walking at this time or that time and changing insulin. And we're not that prescriptive. Just getting people moving seems to be beneficial at this stage.
I had a question as well, kind of related to what Haley mentioned, but in terms of prevention, is the prescription just like our general recommendations for physical activity for the general public, or is there like evidence that, you know, more certain types are better than others?
That's a great question as well. And I wish I had that slide here. It is the current physical activity guidelines. And if you look at the Department of Health and Human Services paper that is the current guidelines that came out, I think in 2018, they have cancer in there, and so they have a whole section on it. What there seems to be is more is better, to a point of about 300 minutes per week, similar to what they saw in that paper. So more is better to a point, but the biggest improvements, like everything, is from nothing to a little bit. You see a drop, and then the more is better to a point.
Awesome.
And not every cancer is on there. It's the 7. There are things that don't seem to be tied, like testicular cancer, lung cancer. Those ones are just, they don't seem to be a signal of cancer prevention with exercise.
That was great, Kristin. I really, really enjoyed that. I have one question kind of related to ongoing research. And I think it's great that you developed a second paper, you and your group, targeted towards like the oncologists. And I'm curious if anyone's studying what impact that paper will have on the oncologists themselves.
That's interesting, like on their attitudes and beliefs or something like that?
Yeah, no, yeah, exactly. I mean, you talked about like that one oncologist, for example, like 60 minutes of exercise, right? And well, now there's all this really good evidence-based information that they can use, and are they, how are they using it?
That's a great question, and that might be something that we should propose to use. Maybe we implement this prescription pad, because we just developed that in the last year, and then we look at attitudes or a change in how many are used or how many hits we get on the website. I think that's a great suggestion. We haven't looked at that sort of thing. We just hope that by putting it there, somebody uses it, but I think it would be helpful to know how it's being used and if we can tinker around.
You'll always have the battle, I think, of maybe getting the oncologist to participate, to be a research participant themselves. But yeah, I was just kind of curious.
No, it's we've had success doing qualitative interviews with them after trials. So we did a project where we integrated exercise as part of standard of care for breast cancer for a while, and we got good feedback from them and pluses and minuses of that through qualitative interviews. So I think this group is definitely engaged at BC Cancer Vancouver. So it'd be worth, I think that's a great suggestion. Thanks for bringing that up. Oh, there's something in the chat, but it may just be, oh yeah, Iris saying bye. And I appreciate, I'm getting close to dinner time, end of a long day. So if anyone does have any other questions, you're welcome to email me. I'm happy to chat about any element of this or related things. So it's great to see some of you again and meet new people as well. So thanks for the opportunity. It was really fun talking to this group and great questions.
Thanks so much for